Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am Jocelyn Turner. And don't mind me, by the way, everybody. I'm playing with my camera tonight. So if you only see from my nose up, it's because I'm trying to find the right position for my camera. But it's not about what you see, it's about what you hear and what you learn tonight. So thank you all for joining us. It's such a wonderful day in Northeast Florida. And of course, I cannot do this alone without my co-host, Dr. Rogers Kane. Dr. Kane, how are you doing this evening?
I'm doing absolutely marvelous. And one thing I look forward to every week is to hear the thump of that nice intro music that we have every week. I just think it's so cool. Maybe we need to extend that and make it a song or something and see if we can put some money in our pocket.
I know I'm dancing. You don't know it behind the scene while it's showing up. But you know what I thought you were gonna say, Dr. Kane? You couldn't wait to see what hairstyle I would have this week, because as I look back over the old episodes with the intro, I'm like, boy, I look different every time, don't I?
I ain't gonna say every time, but most of the time.
Oh boy. Well, listen, we have an exciting evening for a very important topic. Often conversations are related to women. Tonight, we're talking about men and some health issues that they may experience, may or may not experience, or either our family history of men who have experienced prostate cancer, have had a prostate cancer diagnosis, or have had a prostate disease diagnosis. And I've shared in the past my own father's prostate cancer diagnosis, which led to my interest in men's health. So we have an esteemed group of panelists tonight, one of whom has served as a hostess in the past, and that is Dr. Kim Barbell Johnson. How are you doing, Dr. Barbell Johnson?
I am doing well. Like Dr. Kane, I'm just going to say it's always good to see you, Miss Turner. So, whatever hairstyle.
Thank you. And also, and Dr. Barbell Johnson is here with Mayo Clinic, and joining her is her colleague, Dr. Floyd Willis, who, if you're in Northeast Florida, everybody knows who Dr. Floyd Willis is. How are you doing this evening, Dr. Willis?
I am doing fine, Ms. Jocelyn Turner. I am delighted to be here. It is always a pleasure to be in the company of this distinguished group, and it's always a pleasure to be connected to the community, telling the truth, hoping they're pausing for it to listen to the truth.
Well, thank you so much. And also joining us is a gentleman I met a few years ago. And oh my goodness, if you've ever met him, this guy, he's not going to stop until he tells all of America about prostate cancer. And that is from the founder and CEO. And if I botch up your title, please correct me, Mr. Tom Farrington from the Prostate Health Education Network. How are you doing this evening, Mr. Farrington?
I'm doing well, Jocelyn, and it's so good to see you again and to be with you. And also, Dr. Kane, it's good to see both of you again. Always happy to be in Jacksonville, although I'm in Boston where we have snow. I kind of feel the warmth there.
Time for a visit to come back, because we sure had a good time with you in the past when you were here. So thank you all so much for joining us.
Snow and a raggedy team, but go ahead. Raggedy football team. Let me put it.
Oh yeah.
You know what? There are just some things we're not going to talk about, Dr. Kane. But even though I guess we should get the frivolities out of the way and talk about the Super Bowl next week and whose teams did not make it to the Super Bowl. But
we talk about that later.
We'll talk about that later. Okay.
You talk about what Patriots didn't make it. We have made it in a few years, but when we were there, we stayed for a while.
Yeah, well, we got to get there. So I guess
Exactly.
I guess I won't bother you
Exactly.
too much about it.
So listen, on a serious note though, I was shocked last week, as I'm sure a whole lot of people were, about the death of Dexter King. And I was equally as shocked, Dr. Willis, to hear that it was prostate cancer. And I mean, I was just so surprised. Obviously, none of us know what his cancer diagnosis looks like, I'm sure, but just the fact that to hear someone that young, in my opinion, 62 years old, is young to die of prostate cancer. So, Dr. Willis, how about you start out and just really tell us your thoughts about that, or just about so many men being diagnosed with prostate cancer?
It is tragic. I think it's tragic when anybody has to deal with a cancer that can be found and often detected early enough that really good treatments can be provided. It's tragic in that sometimes maybe you can't cure the entire cancer, but sometimes it's about survivorship. You know, you have it and you understand what you can and cannot talk about. Basically, you can talk about all of it and you can live life with it if you have to. But I think the biggest tragedy is there are, and I cannot put young Dexter King in this category because I don't know the facts. But I would just say in general, the biggest tragedy, I think, is the number of people, number of Black men who are reluctant to go in to get screened, who are reluctant to find out about it and learn about it. And so I was just taken aback when this happened to Dexter King. I think, you know, arguably one of the most famous people in the country, his family is certainly one of the most famous in the world.
Mm-hmm.
In all likelihood, he had access to health care that so many people in this country don't have. And still, this tragedy happened to him. So it's devastating. It really is. And anything we can do to keep this from happening again, I think we should. I have 2 or 3 slides. I don't know whether this is the appropriate time to put them up, but if we can, it would take me 5 or 6 minutes to run through them.
We're going to hold off 1 second. I wanted to get, before we do that, I would like to just ask for Mr. Farrington's comment on that as well.
Sure. Thank you. And I agree with Dr. Willis. It is sad to see and unfortunate to see a man that's 62 years old die from prostate cancer. Now, you know, we've been a 24-year survivor and been in the prostate cancer advocacy world now for, this is our 21st year. We've seen a lot of unfortunate deaths, men dying young because of lack of early detection. And also, I have certainly seen situations where men die young because they're diagnosed with a very aggressive disease. And even with the treatments with a very aggressive disease, I have seen men die at that kind of age. But we don't want to see men die from prostate cancer that young. If there is an opportunity for them to beat the disease by detecting it early, and so you know, I grew up during the era of segregation and was very active in the civil rights movement. To see another king die of anything is, to me, is a major loss. So sorry to see that.
Absolutely. Dr. Barbell Johnson, do you have any thoughts? And I know you do a lot with clinical trials, and really, we all know that when it comes to cancer, early detection is the best cure or treatment for it. And obviously there's no cure, but I'll say treatment. But what are your thoughts on that?
Yeah, so about Mr. King, you know, I think that this has been a really interesting couple weeks watching both, unfortunately, Dexter's death, watching the response to King Charles III in the UK, talking about his prostate, And probably even more startling to me, not as tragic, but Lloyd Austin's failure to report that he had prostate cancer, and recent news about just this burden that men have to even talk about it. How the stigma of having prostate cancer is still something that I don't think we appreciate until we see it in the national headlines like we did this week. So I think this conversation is extremely timely. Any death is unfortunate if it's premature, and these deaths are often premature. And because we have opportunities to advance early diagnosis, to advance novel treatments, to move towards more personalized care. As we talk about these, we can bring those of color into this conversation, into clinical trials, and maybe we'll be ahead of the game. But for right now, I feel like my colleagues on this panel that it's just very sad that we've experienced another king's death in this way. And it's sad that we continue to have to address some of these stigmas that we just have not created a space to normalize the conversation about prostate cancer.
Thank you. Dr. Kane, did you have any thoughts? You're muted.
In all honesty, I think our guest has covered it very well. Not only are we tonight looking at prostate cancer, but we're looking at prostate disease, since there's a continuum in terms of what you may, in terms of the symptoms that you experience and the diagnosis of prostate cancer. Just want to make sure that our audience is aware of what to look for, both from the patient himself and from the family.
Thank you, Dr. Kane. And Dr. Willis, if you'd like for us now to go ahead and show your slides, Tyrone, if you can cue that up, and then we'll get back to the discussion.
Yes, it's just a few slides I'd like to run through, and then I would be just delighted if this distinguished panel, including you, Ms. Turner, could just share your thoughts and share what goes behind these slides. I've had so many questions out in the community when we talk about prostate cancer. Some of it beginning with what is it? Why what's it there for? When are we going to cause problems? We've talked about these prominent folks here. U.S. Secretary of Defense Lloyd Austin. Not sure whether he was reluctant to bring forth this information, but he certainly had it, and he's just one of a list of people who've had it. Next slide, please. We just talked about this gentleman. So again, just a tragic thing to happen to him, and there's more and more diagnoses that will be made each day and deaths each day. Next slide. So we're just going to go through these four things. What is the prostate? What makes the prostate unhealthy? When should you get it checked? And how do you treat prostate cancer? And the last two I really need some assistance with. You can see that orange, that bright light there is what the prostate is. And you can see it sits right beneath the bladder, right at the base of the penis. The tube that leads from the bladder out to the outside world through the penis goes right through it. And I think some people don't even know where it is. So I wanted to be sure we educated ourselves on what it looks like. So when we talk about trying to check it, people at least know what we're looking for, aiming at with the finger or anything else. Next slide, please. Now, I don't think the audience is going to be able to see this because I can't see it. Somehow this transposed, but anyway, what does it do? It does a whole lot of things, but the bottom line, probably the most important things, is it creates a fluid. It helps to create this fluid that carries the sperm from the testicles. As it goes from the testicles up through close to the bladder, it goes through this prostate, and this fluid is created. And when a man ejaculates during intimacy, that prostate helps to create that fluid and eject it out into the body. We can go to the next slide. So this, I think, helps to explain why is it that people put the finger in the rectum. That particular spot, and you see that same bladder, and you see the testicles, and you see the penis. When you put your finger in the rectum, you can feel that prostate. You can see the tip of that finger. You cannot feel the entire prostate. You can only feel the top part of it. And I think one of my other guests can probably comment, one of the other guests on the show can comment on this. That is why it's important to have this blood test that we'll talk about later on. Next slide. So what causes it to be unhealthy? When do you know you're having some trouble with it? Well, that first bullet said benign enlarged prostate. Sometimes just as we get older, it swells. In fact, with most of us, the prostate gets a little bit enlarged. It doesn't necessarily mean you have cancer there, but it can get enlarged. And if you look at the gentleman leaning over the stool, you can't get the urine out like you used to. Sometimes you have to get up several times in the middle of the night to try to empty that bladder. But sometimes that can just be from an enlarged prostate. It doesn't necessarily have to be cancer. Then the second one is prostate infection. You can get prostate infection. Sometimes some diseases, chlamydia being one of them, you can catch prostate infection, but not every time do you have to catch it from anyone. You can just get it like you get a bladder infection or like you get a cold, and we can treat that. But the third one is a very serious one, prostate cancer. And sometimes you just can't tell the difference between the three of them on your own. So it's not normal and not natural and not something that you're supposed to stay home with for years and years. You come in to see the doctor if you have any of these symptoms because that prostate is unhealthy. Next slide. So why do you need to get the prostate check and why is that important? Next slide. So what this talks about is Black men having, you see, almost a 30% increase in prostate cancer when they do these biopsies and detections. They have almost 100% higher PSAs in the high range, 20 and more. And when it's higher like that, that means maybe the prostate cancer has spread. And for a number of reasons, which we probably can't get into tonight, Black men seem to have 20% or so more likelihood of being diagnosed with these really bad prostate cancers, the ones that don't necessarily grow slow, but they can really cause trouble in your life, which is likely the kind of cancer that Dexter King had. Again, I don't know. I'm just guessing. Next slide. Number of new cases of prostate cancer per 100,000 men. All those numbers don't mean anything except for the difference between white and Black. We get it more. When we get it, it's more aggressive. When we get it as Black men, there usually is more of a struggle to get to the doctor and get it checked. And that's a whole nother discussion. But next slide. So how do you treat it? A number of ways. Sometimes, and I'm sure those of us with family members who have had it, those of us who have experienced it ourselves, a lot of times we talk about just watching it. If the numbers are low enough, it's a very slow growing disease. And in some situations, you can just observe it. But when you do have, that's that first bullet with the microscope, with the magnifying glass. Sometimes you have to have surgery on it. Sometimes there are hormones that are given. Sometimes radiation therapy, and then sometimes chemo and immunotherapy to treat it. The important thing is, if you find it early enough, a large percentage of the time, it can be treated. Next slide. So the prostate cancer in men of African ancestry is worse. And therefore, it's really important for us to get this message out. So anybody under the sound of our voices now, we are pausing for the truth, but we don't want it to stop here. The truth has to be spread. So anybody that doesn't know all those things you just saw on those slides, please tell them, because to go in and get checked is a very important thing. Next slide. I think I will skip this because maybe Dr. Barbell Johnson can talk about this. I'll mention it briefly. Next slide. It's a big project that we're working on here in Jacksonville, which is comparing how Black men survive prostate cancer, both here in the United States. Actually, it's focused right up at post 197 up off of Spelman Road. But the sister project, or the brother project, is in Lagos, Nigeria. So we're looking at a lot of different things. This is under the leadership of Dr. Folake Odetna, and we have all the partners down below. We are really interested in understanding how people do with prostate cancer and what they know about it. And I hope that you'll see some of this information around town and participate in the Eye Care Project. Next slide. And that is it. I would love to turn this back over to Ms. Turner and have the other panelists, including Dr. Kane, comment on anything they saw in those slides that they think might be worth commenting on.
I can tell you the first thing, having been involved in the Healthy Jacksonville Men's Health Coalition Man Up for Health Summit over the years, the biggest thing that I heard why men don't like going in to get their prostate check has to do with that one picture that you showed, and that is the digital rectal exam. It's uncomfortable, but Dr. Barbell Johnson, I had to go there and tell them. Then, they don't know our pain all the years we've gone for a pap test, right?
Say that.
Really, I mean, I just had to go there with them. Like, man, really, you're talking about a few seconds that could make a difference as far as the quality of your life. And Dr. Willis, as you were talking, what came to mind for me are the years of potential life lost. We joke as ladies telling the men in our lives that if you don't take care of yourself, don't worry about it. I have a nice insurance policy when you're gone. But the years of potential life loss, Roger Williams, the president of the Men's Health Coalition, always said, I want to walk I want to be there for the birth of my grandchild. I want to see my grandchild graduate from high school. Just so me, what's your thing, right? And so when you don't take care of yourself, the years of life that you lose, the years of life you could have potentially had you only gone in, Mr. Farrington, for those very important exams and listen to the conversations. And what I liked about Man Up for Health and the conversations I know that Finn has around the country with men, Black men in particular, is the importance of going in for routine exams. And for some strange reason, men just don't want to do it. They don't pay attention to the signs. So Dr. Kane, can you talk a little bit more about, what are some reservations or hesitations you get from your patients about going in, and maybe they'll come to you, you're convincing?
Yeah, I can, but what I want to hear, because Mr. Farrington mentioned before being an 11-year survivor, what was did he have any hesitations prior to being diagnosed? He's an actual survivor, so I'd like to get his input on what he thinks and how he feels about this whole process.
Well, first of all, thank you, Dr. Kane. 13 years ago, I was an 11-year survivor. Today, I'm into my 24th year. So that's a big difference, and I'm blessed to be here. But it's interesting. When I was diagnosed, it was because of screening. It was a different world back then, 20 years ago, because your primary care doctors routinely would give you both the digital rectal exam and a PSA test. And just from looking at the numbers from the PSA test, my primary care doctor referred me to urologist. So that's how I was diagnosed. And I was diagnosed I was diagnosed with what's called today is intermediate unfavorable. I had a Gleason 7, 4+3. And so that put me into the intermediate unfavorable category. But today, it's a different world for two reasons. Number one, men now often have to ask for a early detection screening because a lot of the primary doctors don't routinely provide it. And second is that the digital rectal exam today, with the protocols for screening, it is not any longer the first test. The first test is the blood test, which is a simple prick. And I know some men don't like the needle. I don't like the needle, but you don't have, I don't think, the hesitation with a needle that you do with the digital rectal exam. And one of the interesting things is that my primary care doctor did not feel any abnormalities with the digital rectal exam, but the PSA was high. So there really, if you want to live and be with your family, there isn't an excuse for not being screened for prostate cancer. Well, unless you cannot get a test or afford a test. And those are issues that the advocacy community are trying to deal with today. Because a lot of men, if you can't find free PSA testing, which are no longer as plentiful as they used to be, then sometimes you really have to pay. So we're doing things on the legislative side to try to get that test done and covered more. But my experience was that I lost my father 3 months before I was diagnosed with prostate cancer, and I lost both my grandfathers to prostate cancer. I should have been aware of my risk for the disease. I was not, and I was shocked when I was diagnosed. Nor did I have any real understanding or knowledge about prostate cancer. So, I looked in the mirror and said, Tom, you thought you were smart. You're not too smart. You had this family history, and you didn't know anything about prostate cancer. So, if you do have a family history and you're a Black man, you are really at a very high risk for being diagnosed with prostate cancer. So Black man, and you should be screened. Black man with a family history, you should run to be screened. So that's what I have to say now. And, we can get into some of the other discussions. I'm anxious to hear from everyone here, but you do need to get that PSA number and go from there.
Well, I will say you talked about 20, 30 years ago. I am an old school guy. And so I remember experiencing where the first thing we would do back then was, we recommend doing a digital rectal exam.
Right.
I call it Dr. Dre at the time.
Uh-huh.
Digital rectal exam. Anyway, but so then the PSA at that time was more of an add-on. Today, it's kind of reversed. The PSA is one of those first things you want to do, and the digital rectal exam is an add-on to it. And one of the reasons Floyd pointed out earlier, and that was when you access the prostate from the rectum, because they only separate it by as much as the skin that's between my first and second finger. They only separate it by that much, and you can really feel the prostate pretty good, at least the posterior lobe of the prostate. You still have that part of the prostate up front and beyond what you can reach with the digital rectal exam. But that PSA can give us some number that we can help use as a guidance toward how aggressive we need to be in terms of our testing. Obviously, you add into the genetics, you add into, and by that I mean your family history. And then, of course, there are other chemistry tests that even more detailed being done these days. I leave that up to the specialists. Since I'm just a jack of all trades and a master of none, I leave that up to those guys who are, that's what they do 24/7. So with that being said, I too am one of those individuals whom, I'll talk about that later, but I'll talk about my family history and where it goes, because I know we're about to come up on our history-making moment, and we always want to get to our history-making moment. So you guys, we're going to go ahead and let Tyrone run with our history-making moment, and then when we come back, we're going to proceed with this discussion.
Don't go anywhere. We're pausing for the truth.
Welcome to our weekly series on History Makers. Today, January 30th, 2024, we highlight another history maker who has made significant contributions to society. Today, we are proud to present Dr. John Carpten, who was the first African American to chair the National Cancer Advisory Board. Dr. Carpten has been a national leader in health disparities research and has been a tireless advocate and key voice for reaching underserved populations, ending disparities in cancer outcomes and care, and building a more diverse workforce in cancer research. He has made pioneering contributions to our understanding of the biological basis of cancer disparities, and his work at the leading edge of cancer genomics has led to landmark discoveries of prostate cancer susceptibility genes. Dr. Carpten has also been named a science trailblazer by Spectrum magazine in 2006. and was awarded Susan G. Komen Distinguished Lectureship on the Science of Cancer Health Disparities in 2014 for his untiring work in ensuring that all people are equally represented in science and innovative healthcare. Welcome to our weekly series on History Makers.
Okay, so I pick up real quick where I left off. I think one of the things that we want to make sure that we get a good understanding of is about the digital rectal exam. You know, again, I personally don't mind doing them, but I think sometimes what some of the patients have an objection to is I do them and then I wind up sending them to the urologist, who's the specialist for things like prostate cancer. Sending them to that individual, then they wind up doing it, and it's going like, okay, I'm going to let one guy do it. So if I have one guy to do it, I let the guy who does, that's what he does all the time, is let them do that digital rectal exam. Because, and what I do is I make sure I'm adamant to that patient, the need to see that urologist. I harass them to death, have my staff harass them about going to see that urologist to follow up on it. And of course, I've done my preliminary work on that. One last thing I'm going to say, and I'm going to turn it back over to our guests because they got more knowledgeable information than I do. But one of the things in terms of those symptoms that we discussed before with that, what they call BPH, benign prostatic hypertrophy, which is just enlargement of the prostate that's not necessarily due to prostate cancer. And that is, you know, you start noticing the slow urination. That's one of the first things we start looking at. Doesn't mean you have prostate cancer, but it could mean for sure that it can be a very enlarged prostate. You know, I always tell my patients, and not to be too graphic, but I always tell my patients, you know, one of the things that alerted me to my BPH is that I'm at the movie theater. I'm going in and I got to use the men's room, and there's 3 or 4 of these little kids coming in, vroom, vroom, you know, they gone. I mean, they in there and out, and I'm still standing up there trying to finish. So that told me, you know, that it made me have the realization like, no, I better go ahead and go see my urologist or go see someone about my prostate to be sure that I'm in a good position to not have to die from an unnecessary, not to have died from an unnecessary, I say unnecessary, disease because I ignored it, or I didn't, you know, want to really entertain the possibility that I may have it, especially when it's because of our ego as Black men. You know, we're omnipotent and this, that, and the other. Signs of weakness is all the kind of excuses that all of us make. And so we need to just put that aside. And our women are quick to tell us, you're not God, you're not, you know, Hercules or whomever. And they will straighten us out real quick.
So I guess the thing I think about when my dad was diagnosed, he had been going to the doctor, and I want to make sure that I stress this of all things. If you have a medical home, have a doctor that you're going to on a regular basis. They're not only checking your blood pressure, your cholesterol, your blood sugar, but as men, they're also checking your PSA level. My dad's PSA level went up from one year to the next. It went up just enough for his doctor to say, what's going on here? And then sent him on for further tests. And fortunately, Mr. Farrington, when you were talking about your prostate cancer diagnosis, his was caught early, if you will. And so he had options for his treatment. And so I immediately, and this is the other part, Dr. Barbell Johnson, I think what you alluded to earlier, I immediately told my brothers, well, now you're at risk. You need to make sure that you're going in for your annual prostate exam. So I guess the question that I have is, at what age should men start paying attention to their PSA levels? And it doesn't matter if with your race or your family history. Whoever wants to take that one. Don't you all answer at once.
I could certainly. We haven't heard from Dr. Barbell Johnson, so I was leaving that for her.
Yeah, well, I'm in a little bit of a different space. So I'm going to let Dr. Willis definitively talk about what our United States Preventative Services Task Force says and what we should do by prostate family history. But I do want to address a couple things. There is the space that we're talking about detecting cancer, finding the prostate cancer. But in the research space, what we're also trying to do is figure out who's at risk. And so we know some family history, but why? So there's that genetic component, but there are also other epigenetic things that we're looking at. We're looking at prostate's relationship to diabetes and to different markers in the blood. So as science advances, we are hoping that while the PSA is a prostate-specific antigen test that we have right now that we can use, starting to screen man. It is looking for cancers, but it will also miss some cancers, just as the digital rectal exam will miss some cancers. And the reason that this has been up in the air in the scientific community is because we don't have the perfect anything. So, because we also want to find the best test, we are working on ways to use spin-offs of the PSA test to improve our our chance of detecting earlier. And so you will hear of more test in that arena in the scientific space, in the clinical trial space. And we should be part of those conversations. You should be asking your doctors, hey, doc, is there any prostate specific, even if your prostate PSA is normal, are there any tests or research trials that I could be a part of so that you can advance this conversation for people of color? Because those conversations are happening and those trials are happening, and we have to we have to know about help ourselves to find out about them and help our patients to know about them. And so there's the prevention, and then there's the screening and early detection phase. And we can move on to diagnosis, staging, and treatment. But as we've talked about genetics, prevention, and early detection, I just wanted to say that this is still a very developing area. And while we are still Black men are still twice as likely to die of the disease. We are working on trying to figure out why they're more likely to have it in the first
Any
place,
questions?
and what can we do to find that sweet spot, you
Mhm.
know, get it even earlier than the recommendations are, because we moved in the same way for breast, and we realized that Black women were actually being diagnosed earlier than our recommendations. So we moved that 5 years back to where recommendations for mammograms are now earlier, and we're looking at the same thing in the prostate space. So, Dr. Willis, I don't know if you want to just
Yeah.
talk about since
Oh,
you're
I'm
seeing
just
your
itching.
patients.
I am just itching to comment on this because, you know, there's a lot of science out there that will say a lot of different things. There's a lot of screening guidelines out there that will say a lot of different things. You can look on the internet right now and it will say men should be screened at age 50 with a PSA. You look other places, it will say men at high risk, African American men particularly, should be screened at 45. You can look other places and it will say 40, which is what I would prefer, around 40, right? Whether you have family history or not, when someone gets close to 40, I begin to talk to that person about getting the PSA screening. If they don't want to do a rectal evaluation, I'm just like Dr. Kane. I give the options. We talk about the pluses and the minuses. I can only feel a third of the prostate anyway with the digital rectal evaluation. But I worry about the mixed messages. I won't say mixed. I'm not trying to blame anybody at all, but I'll give another example. You screen for colon cancer at 50, except if you're African American, you do it at 45. Now the guidelines are saying, let's screen everybody for colon cancer at 45. I really feel it's in coming years, they're going to say, except if you're African American, let's start at 40. So I really feel like, to be safe at age 40, as Dr. King was suggesting, go talk to somebody. If your wife is going for a mammogram, just say, buddy, mammogram pap smear. If you go, I'm going to go. I'm going to go to my doctor. I'm going to talk to about my prostate. If they say you don't need a PSA, you're too young, you're 41, you don't have any health history, fine. I think most of them, if someone comes in and they show an interest, at around 40, particularly Black or family history, as Mr. Farrington was saying. If you've got family history, we screen earlier. And so I often try to encourage my patients to not get confused by the guidelines. But if you're a Black man and you're 40, sit down and talk with someone about whether you should or should not have a PSA. And if you are my cousin, my brother, my father, I would do it at 40. Yeah. I'll stop and see what others.
The truth
I'm listening in right now.
I was going to just add that the unfortunate part of it is sometimes our insurance coverage is driving what we have and when.
Okay,
so
wait. Ooh, I got to talk about that one. Okay, cut me off if I'm talking too much. But you are absolutely right. So here's my perspective. I've heard that one. The guidelines say I don't really need one. It doesn't come with my insurance screening that they pay for once per year. You know, the American Urological Association and others they say consult with your primary care physician and have a discussion to decide. But you can get a PSA. You got to have the $50 or $100 somewhere in this town for somewhere around that price range. You can get a PSA. And if you really think it's important or your doctor thinks it's important, that is one of those things you invest in. I completely understand Mr. Farrington's point. We really ought to be free and we ought to have a way to get that screen for everyone. But until that happens, it is not a $5,000 investment in your health. It is a $50,000 investment. I mean, it's a $50 investment, $100, you know. And I am not immune to the fact that some people don't have $50 or $100. I mean, I know that. I've talked with people, I have patients like that. We have to work on that and we have to figure that out. But it's a very important thing, particularly for Black men, to not let anything get in their way of diagnosing this early, because it's just too many lives being lost. I'll stop, but that's a great question. I just had to. That was just my soapbox. Tomorrow to say that's not right, Floyd. You shouldn't have been saying that. And that's just that's not a guidelines. That's not Mayo Clinic. That's
it basically is a guideline. I mean, some of the guidelines I have been. You mentioned the Preventive Services Task Force, and you know, as an advocacy organization, we've been fighting them for a number of years. I mean, since they first came out with don't screen anybody. No man should be screened for prostate cancer, and kind of fighting that position to where we are today. And we've got them. They finally came out with another guideline of, I guess, in a few years ago, it was 2018, and it's still not where it should be. I'm 100% with Dr. Willis. You know, we do a lot of education around early detection screening. We have a website, finpsa.com. You go to finpsa.com. We talk about each one of the screening guidelines. Our position is 40. You know, do something at 40. And I also serve on the National Comprehensive Cancer Network guidelines panels for early detection and for treatments. And so I've been in a lot of debates and a lot of discussions around screening. And, you know, I know in the NCCN guidelines, we certainly have 40 for high-risk men, for African-American men is when you should begin that process. But there's still a lot of confusion out there around
there. I agree. There is in the cancer screening space, but in this space in particular, there is an evolving conversation. And I do think that a lot of it, what you've said is exactly true. Push for the opportunity to get to the kind of testing that you need, seek resources. If you really think that you should be getting the test, but it's not covered by your insurance, make an intentional choice to potentially save your life in this space, at least to get a baseline. And if you're symptomatic, then do more research. Look at organizations that can actually help you. I took my dog to the doctor today and I got a one-pager of all the organizations that that I could have used to get his diagnostic work done or to get the chemotherapy for my dog that are available to provide. And it would take research, but imagine if it's my brother or my father, or, I think we need to continue to push the envelope until we are better served by some unified guidelines. I wanted to just say that that is a reality, unfortunately, because 50 for you or 50 for me is not the same 50 for everybody, but it is worth it. It's more than worth it to get that check. But there are resources out there, your organization being one of them, that can help to guide patients. And so if you get a no, there are ways to get around that, to get that test. And that's my message to Black men in particular, men of color in particular, and symptomatic men for sure. And I think that's unfortunately the message that we must push.
Well, as a pause for the truth, participating individual, I think most of you guys know me, and I don't. One of the reasons we created Pause for the Truth is we don't have time to sit back and just go with the traditional approach for the non. Be quite frank with you, I really have to look at. I take care of a lot of African Americans, so I shoot straight from the hip, and I have to just go ahead and go out there. What I will say is for 20, I'm gonna say 20 plus, maybe 25 years, I've always been an advocate starting at 40. Okay. Mm-hmm. And it was a battle back then, not as much of a battle right now, but it's still a battle. The other part that I want to say is that when we, as we have a lot of Black physicians listening to this show, or physicians listening to the show, and you have to be an advocate for your patient. Sometimes you have to just go that extra mile to make sure that, one, the patient gets it, but two, if there's some place where that can be covered, I'm not saying lying on anything. I'm just saying dig deep, look and see where you can get that paid for that patient, because it needs to get done. Okay. 3, I don't necessarily, one of the confusions that we sometimes see with people and what they do with my patients, that they come to me and say, hey, Dr. Kane, what's the normal PSA? And I say, oh, it's listed, on Questa, LabCorp at, 4.0. Well, look, mine's 3.5. One of the things I say is, well, what was it last year? Because you start looking at the rate of rise with that PSA, and that might be as an early indicator or an indicator of prostate disease. A PSA doesn't just, because it's elevated, says that it's prostate cancer. It may say that it's prostate disease because of the size of the prostate. And what people have to remember, what PSA stands for, it says prostate specific antigen. And it's just what it says. It's specific to the prostate. It's not being produced by your lips or your nose or your eyeballs or anything else. Produced by the prostate. So it can help give you a clue. I'm not saying being diagnostic in terms of what it represents, but it can help give you a clue as it relates to prostate disease. And so the bigger the prostate, the more the more PSA that can be produced. Okay. And so it may not be that it's prostate cancer, but just an enlarged prostate. Either way, you're still at higher risk than somebody who has smaller prostate. Not saying that only large prostate develop prostate cancer, but you're still at a higher risk. You definitely at a higher risk being an African American. You have to look at the epigenetics, as Dr. Kim Barbell Johnson referred to, and that means the circumstances by which your body and your family's body were exposed to, whether or not it was because you lived in a house that was built on some landfill, or whether or not you're in an area where you can't get it's a food desert, and so you eat all the bad foods that may increase your risk for prostate cancer. It's so many factors that are out there that can affect it. And so it's up to your primary care physician to let you to stay attuned as to, yeah, it's fine looking at those screenings and recommendation, but again, they have to look at you as the individual and what those recommendations and or represent to you as an individual. A Black man, 45 years old or 40 years old, he's got a almost elevated PSA. You might be 3.9, but you're 4, or Do you see a rate of rise where it went from 1 last year and it jumped all the way to 3.5 this year? All those, those circumstances are one where you may be at risk. And the last thing I'm going to say is to Black women, and this may be a little controversial to some of our guests, but hold your husband hostage. If he won't take care of himself, you don't get no nookie. I'm sorry. I have to say it that way. That might be the way to help get him to see the doctor. Oh no, you want to play, then you got to pay. Go see your doctor and get tested.
This is the part where I will interject and stop the pain. But I do want to add 2 points I want to make. One is when we talk about men and going in for exams, a lot of men just, and correct me if I'm wrong, I'm going specifically from conversations over the years when we did Man Up for Health. Some men don't go into the doctor until they start having some erectile dysfunction or some difficulties with erection, right? And so is it at that point that there is potentially a prostate disease issue going on, or could it be related to some other chronic health conditions?
If nothing else, it represents an opportunity. I'm going to let somebody else answer back that specific question, but it does represent an opportunity by which you can start testing that male. But I'll let one of the other guests address this.
Yeah, I was going to say that usually by the time you have symptoms, it gets your attention, but something has been brewing for a while. And you're right. Sometimes we have the symptoms, or men have the symptoms, and they say, oh, it's because I started new blood pressure medication, or it's because I'm tired, or it's because I was drinking last night. That's why I didn't get it up. Like there are all these excuses that we make for ourselves, and we don't make it into the doctor. I'm going to be a little more inclusive than Dr. Kane, because I don't think this is a husband or wife, but it's a gender thing. Whether if you had a prostate at birth and you still have that prostate, this conversation is relative to you, independent of how you identify your gender. And I think those are the things that we must continue to do, both in the transgender and the non-transgender communities, because Black men are Black men and they are dying at a disproportionate rate. I also want to say, though, Jocelyn, that you're absolutely right, that having symptoms is sometimes or Dr. Kane, what brings you in to get anything addressed. And so, like I said, we're seeing associations with other biomarkers, with other chronic diseases. And that doesn't say that because you have one disease, you're going to get the other, but the likelihood it might be increased. We're also looking to see if we can use those markers to add another layer to early detection. If you have those biomarkers, and your PSA is normal, are we able to say that you're at greater risk and your screening should be higher than the current recommendations? When you look around our community, we've got buddy buses in every community, right? We have breast screening on every breast every October. You can have 4 mammograms if you want to. Nobody's going to ask. We don't have PP buses. We don't have anything in the community where we're just setting up the community to do like random, prostate. Probably because who's going to come? We still have a lot of educating to do, and then we have to create opportunity with the education. So I think this kind of form is extremely important. But the reality is that we can do more.
I'm glad you said that, because hold on a second, Mr. Farrington. I'm glad you said that, because we did Man Up for Health for more than 12 years, and people have asked me, how come you don't do it anymore? And I just will be honest with them publicly and say, because as Dr. Barbell Johnson said, a lot of attention is focused on women's health. It took a whole lot of painful effort getting financial support to support men's health, community men's health screening events. Over the years, initially we had the opportunity to have the PSAs done on site at the Man Up for Health event. Over the years, that opportunity was taken away. No more community PSA level prostate cancer screenings, right? And so really, if more opportunities were made available in terms of financial support, there are volunteer groups like the Healthy Jacksonville Men's Health Coalition who's willing to do it. And now, before I let Mr. Farrington have the floor, I have to say what messed me up, Dr. Barbell Johnson, recently when I found out, because my dad had prostate cancer, when you talk about genetics, I'm now at a risk of developing breast cancer. And see, we don't understand the genetics behind cancer. Go ahead, Mr. Farrington.
Right. And you are absolutely right about genetics, but I do want to bring in another factor, and that is because we talked about the issues with erection, but one of the reasons that a lot of black men are really concerned about even a prostate test is because they feel that if they are diagnosed with prostate cancer, it's going to impact their sex life. And that's one of the detriments right now to getting screened for prostate cancer. And our message is that a good sex life is really dependent upon a good prostate. So if you have prostate cancer and you allow it to become uh, a spread, then your chances of treatment to save your sex ability can really go away. So early detection is important for your sex life post prostate cancer. That is a reason to get screening and the early detection, and not something that should be feared.
And because of that, I have to put a shameless plug in for clinical trials. So, when you think about the impact of radiation or surgery and having the potential impact for impotence, we have these evolving therapies and treatments in trials, whether they're focal laser ablation or focused ultrasound types of therapies. And if we can be in those trials and see how we respond, those trials are evolving to decrease the risk of some of the side effects and some of the adverse impact of treating the cancer. And so we are evolving in that space very slowly, but we're not as a culture, as a community in that space. So we must continue to encourage our patients, our family members to be involved on the forefront of clinical trials so that these recommendations can be built with us in mind. And the only way we're going to do that is for the clinicians to, again, just be robust and aggressive and intentional about trying to find those clinical trials that might be of benefit to our patients.
May I make one final comment before I know you guys are going to have to close this out? Um, but it's to Jocelyn's, your point, and Dr. Kane's point. Last time I looked, I think 75 or 80% of the healthcare decisions in this country are made by women, household healthcare decisions. So this is a shout out to the women. I think you're making the decisions anyway. Just go ahead and really encourage that, not just husband, but man, father, uncle, because they may not do it without your influence. Without even knowing it, you've been influencing their healthcare decisions probably all their lives. So let's make all of you ambassadors for prostate health. Find 4 or 5 men to talk to tomorrow that you love and care about, and let's encourage them to go talk to someone and or get screening.
You
And
know, a lot of times they want to claim.
I'd like to ask though, Dr. Barbell Johnson, when you talk about being involved in clinical trials, what might the clinical trials entail though? Because, even when I was talking to someone earlier today about the show, and they said, I know you've been doing working on some research studies. What does it mean? What does that entail being a part of a study? Are you going to be doing some poking and prodding, or what might it look like?
I'm so happy you asked that because it could be that, but more likely not that. I think that what we need to understand that clinical trials can be anywhere from observation and seeing what happens going forward in time with no intervention. They can involve ways to early detect and screen. They can look at nutrition, the impact of certain nutrients on the health of your prostate, as well as what treatments are more efficacious and safe, what doses are more specific for any of the modalities for treatment. So the ecosystem of clinical trials is an ecosystem. It's a large space. And Dr. Willis mentioned something, and he used the word survivorship, which is a very important space. So even after you've been diagnosed and treated for cancer, we are still concerned, and we want to make sure that not only do you get the treatment, but you live the same quality of life. Like you have the Farrington badge and health outcome that Mr. Farrington has, because we're not seeing that as well. And we know that we need to understand why. Why is that? And we understand some of that has to do with social determinants. Some of that may have to do with just how the disease progresses after treatment based on the treatment that you had. So clinical trial will help us to get closer to that kind of personalization of decision making, and it could be anything. So because you hear clinical trial, it may not just involve a therapeutic, a medicine, or a test, but I think that just knowing what's available puts you in charge. It's if you ask the question, you're in charge, right? So
Let me add a little bit to that, and I don't want to talk about Finn because I could do that, as you
But
know.
you can. Go ahead.
But we do have a clinical trials program, and if you go to Finn Trials, that's PHENTRIALS.com, we have information about what clinical trials are. We also have a database of all actively recruiting prostate cancer clinical trials. And we have a Find Your Trial tool where you can literally, depending upon where you are in your prostate cancer journey, even if you've just been newly diagnosed, you can find trials at that point in your journey. Or if you've been along your cancer journey and have metastatic disease, you can find clinical trials there that are actively recruiting. So that information is available, and as I said, all of the actively recruiting prostate cancer clinical trials, we get that information from clinicaltrials.gov, and then we put it in a format that patients can understand, so you can understand how to access this information about the trial, where the trial is located, and other information is available to you. And we also, the one thing I have to talk about is our treatments portal. We have finpath.com and the NCCN guidelines. And I mentioned that I've been on that panel for over 10 years. And so I've sat with the leading doctors, prostate cancer doctors in the country to really outline and define treatment options based upon new therapies that are introduced. And so we have finpath.com with all of the treatments based upon those guidelines. And you don't get those guys, you don't get to say that. I can't say that unless that information is verified. So every time the NCCN updates its prostate cancer treatment guidelines, we update FinPath, and then the NCCN audits our finpath.com to make sure that we're presenting that accurately to patients. But again, it's in a format that patients can understand and use. So when it comes to early detection screening, we have finpsa.com. When it comes to treatments, finpath.com. And when it comes to clinical trials, fintrials.com. So those are our prostate cancer educational tools. And we have a lot of other information around. And we even, at some of our events, we provide free prostate cancer screening. And we do that in partnership with other people, but we try to bring that together. I can't remember whether we had free screening when we were in Jacksonville with our play or not. I'm not sure that we did, but we do it a lot of places. So, the fight against prostate cancer, is ongoing. And unfortunately, a big issue right now is kind of bringing all the parties together so we can have a targeted fight. And as opposed to people, all over the space without a consistent message. For Black men, we are the leading patient education advocacy organization focusing on Black men. Go to our website and you will find information, and we will be happy to support you.
you're going to see an uptick in all of us using that website, because that's a necessary tool that and portal that we need in this community. So thank you for sharing that. Tyrone has an example of a trial that we are doing at Mayo Clinic that you probably have on that list. Tyrone, I don't know if you can upload. That's the support group, but there's the other PDF file that was sent over. And so when you talk, Ms. Turner, about trials, this is a trial that Dr. Jerry Colon, one of our oncologists, medical oncologists here, has been running exclusively for Black men who have had prostate cancer, looking at low levels of vitamin D, understanding that there are things like vitamin D, that is the intervention. If it's low, you replace it for 8 weeks, and then the biospecimen that they're collecting to look at the response to that vitamin. And that's a huge body of information, both in urology and in GYN care right now. But it could be as simple as and I don't want to say oversimplify what a clinical trial is because it's a very regulated study, but it could be an intervention like vitamin D, which we know when we look at inflammation across the board, that has is part of a lot of different conversations with chronic disease. So if this is something, if you have had prostate cancer and you think you're not taking vitamin D replacement by your physician, you may have had a history. This QR code that's here can lead you to more information and direct you to our coordinator who is actually screening and enrolling for that trial. This is just one of the examples that we have, but I want you to know that this trial is one of the trials that Mayo Clinic has applied again to the Department of Defense to kind of make an international study using decentralized ways. You don't have to come to Mayo Clinic. We can come to you to kind of get this information. So we're working as much as we can with the trusted sources that you see on this call. But I totally agree that we need to do this together, collectively, and to share that information. And that's one of the big things that we're doing is we're making sure that the information that we have, we are dedicated to sharing that information with those who are participating as clinicians or as participants in our clinical trials.
Dr.
Thank you,
Barbara
Dr.
Johnson, you
Woodman.
said something that was important, I think, is that we're in this together. And I think both, I think Mr. Farrington and Dr. Barbara Johnson and Dr. Willis, you guys are all on the same page as it relates to we need to get some clinical trials done. That specifically, and when I say we, I'm talking about Black folks right now, that specifically address issues concerning prostate disease and prostate cancer with Black men. And I think that it's one of those things where you can work together, and it's not anything that's. I just want to make sure the audience understands. It's not a competition on anything. It's about all the efforts, some of the efforts that are taking place in our communities, by which we're trying to address prostate cancer and prostate disease in Black men. Okay, we know it doesn't just occur in Black men, but somebody asked a question: is it true that 1 in 6 Americans, I think it was,
Black men will be
Black
diagnosed.
men, yeah. And the answer to that is, you guys can correct me if I'm mistaken. The answer is yes. It's about 1 in 6 is give or take, a couple of decimal points. But yes, the answer is yes. That 1 in 6 of us, and that's a huge number. I mean, just think about it. How many cousins you got, and you look at 10, 12 of your cousins that might be sitting across from you, and 2 of them may have prostate cancer.
And Dr. Kane, there was also a question about if you all could talk about first degree relative.
Yeah, Dr. Jones did that one. I don't know if anybody else, because that Ken is really up his alley as it relates to breast cancer. If and I don't know if y'all may have the answer to it. I don't, but I know Dr. Jones is.
If there one or two people in your family, a woman, 1 or 2 people in your family with prostate cancer, it does, from my understanding, slightly increase the risk of breast cancer. But we'd have to get a Dr. Colon or medical geneticist to go into the detail. I think it's a really interesting genetics and epigenetics question. But I still go back to the bread and butter of getting screened, whether for mammograms and for a prostate cancer. And I don't know that it necessarily means understanding all of your genetic tree. It's about getting out there and doing the bread and butter. I know I'm 40. I know I need a mammogram. I know I need a PSA, and getting that done on a broad scale.
Correct. And if you look at the genetics, as in breast, where most of the breast cancers are not genetically associated, I think you'll find that consistent. So we don't want to limit the history. We want to respect the history, but we don't want to limit the history. I think the risk factor of being Black, of having West African ancestry by the data that we're seeing from Hopkins, and the great history moment, because John Captain, who was presented at the top of the hour, he is one of the leading cancer specialists in this country internationally, and he's the director for City of Hope Comprehensive Cancer Center in California, well respected in this work, and we all work together in this space. So I think that we have a lot of advocates, a lot of allies working in this space. So we can move this ball along if we do work together and if we continue to bring our patients and stay patient focused in this arena.
Great job, Tyrone, in terms of bringing up Dr. Kevin.
I know
Great
we've run over.
So we've done this has been amazing discussion. When we invite our guests on, we don't plan on taking up your whole evening, and recognize that this is probably going to need to happen again. We need to further the conversation. There are a lot of things we did not talk about, but thank you for your patience in allowing us to go beyond the 1 hour time limit. But we will wrap it up by first thanking you all for participating. But at the end of every show, we like to give our guests an opportunity to share their final thoughts. And of course, I'm going to go with ladies first, and allowing Dr. Barbell Johnson to share your final thoughts regarding tonight's topic.
Thank you so much, first of all, for having us. I started talking about the multiple people in the news this week. And one of the statistics that I was most impressed with, because of socialized medicine, the UK could track the number of men after the king announced that he had just prostate hypertrophy that actually went and got their PSAs and their prostates checked. And it was a 10,000% increase in the period of time since his announcement to when that data. I would love to see Black men honor Dr. King and his son by using this kind of momentum to do the same thing. We may not be able to measure it in the same way because of the lack of socialized medicine in this country, but if we can just see our Black men showing up just because we are honoring the legacy of those who have died unnecessarily early, whichever the case may have been. But this is what I would love to see these kinds of this discussions result in. So thank you very much, and I hope that we can continue the conversation.
Thank you, Dr. Barbell Johnson. Mr. Farrington, what are your final thoughts regarding tonight's discussion?
First, I want to thank you for the opportunity to be with you and be part of this. And I want to echo what Dr. Johnson just said. Really look at the life loss with Dr. King's son, Dexter King, and take action on that. The other message that I have is that prostate cancer kills. If you're diagnosed with prostate cancer in early stage, the probability of your surviving to 10 years is over 90%. That's what the statistic says. That's the information according to the American Cancer Society. If, however, you're diagnosed with prostate cancer at a later stage, your chances of surviving 10 years goes from about 18 to 35%. That's a big difference. And you want to be in that 90 percentile group. And the way you do that is you take action, you get screened, and you manage your prostate health. You don't get screened one time, you continually get that information, and you know your PSA number.
Thank you, Mr. Farrington. And can you make sure you drop your contact information, or at least your organization's website, in the chat, and we'll make that information available to our audience. Dr. Willis, last but not least, what are your final thoughts regarding tonight's topic?
My final thoughts regarding tonight's topic is really just to thank Dr. Kane, Mr. Farrington, and yourself, Ms. Turner, because this outreach and communication, the power of it cannot be underestimated. This message has to be spread. And I think you have a fantastic tool for doing so, Mr. Farrington. I know you do this all around the country and all around the world. There's more of it that needs to be done. We just have to get the message out. So thank you for this effort, and I am honored to be a part of it.
Thank you, Dr. Willis. And Dr. Kane, what are your final thoughts regarding tonight's topic?
Well, first of all, I want to thank all of our guests. I think they did an excellent job. I think that, as usual, our time cuts us short in terms of all the stuff that we like to talk about. But because we like to be respectful of our guests' time and that they have families and so on and so on, that we typically try to keep it an hour, but we're approaching an hour and 15 minutes right about now. So I'm going to be relatively short. I am also a member of a family that has prostate cancer. with an immediate relative. I have a brother that has prostate cancer, a father that we believe had prostate cancer, but because of old school thoughts at that time, he didn't really go and get checked and looked at it like he should have. I think that we and I'm talking to physicians right now, especially primary care physicians, I think we have to we need to be very aggressive with trying to make sure our patients get that opportunity to get tested and to be examined for prostate cancer. By any means necessary, you know how I am. I get kind of raw at times, but it's still the truth. Hook, crook, or steel, I need these. We want our relatives and our friends and our family, the rest of our family, we want them in to get examined and looked at for prostate cancer. Lastly, I'd like to thank everyone that came in and looked at the program and hope that at some point we can go on ahead and look at this subject a little later and we get greater participation. Make sure you spread the message about Pause for the Truth. Like us on Facebook. I'm not sure, Ms. Turner, you're going to clean this up, but like us on Facebook because it helps us get our message out to a lot bigger, much bigger audience. And with that, I'll say good night.
Dr. Kane, I'm gonna let you get a drink of water or something to clear your throat, and if you need to finish your thoughts. Tonight was a very important topic. The Super Bowl is happening soon. Make the Super Bowl of your life the conversation about prostate health with your loved ones. It is a very important topic. When you plan your family reunions this summer, make sure that you include a segment on knowing your family's health history. When you draw your family tree for your t-shirts and all your decorations and designs, add what diseases each family member had or has, because it keeps the conversation going for future generations in reminding people of the importance of going in for routine examinations, routine screenings. And if you have the opportunity, take your loved ones to the doctor. There is a day called Take Your Loved One to the Doctor Day. Look for it. Most of us are so good about Googling things. Google when it is important to learn those things that are important to learn about our health. Thank you as always for tuning in to Pause for the Truth. And by the way, please to subscribe to our YouTube channel. It allows us to get this message out about our Pause for the Truth podcast. And tune in next week as we have more important discussions. And thank you again to our guests. Good evening.
Good night.
Welcome to Pause for the Truth. We are grateful that you joined us today and hope you've gained valuable insights on our current topic. We look forward to having you with us next time as we explore trending issues in our community and discover ways to simplify life for you and your loved ones. Our dedicated panelists and staff are committed to sharing knowledge and serving our community. But now, we need your support. Please subscribe to our YouTube channel and spread this valuable knowledge to others. Don't forget to invite your family and friends to tune in to our podcast every Tuesday at 6:30 p.m. EST. Visit our website at www.pauseforthetruth.com and show your support by liking us on Facebook, following us on Twitter, and linking with us on LinkedIn. Feel free to email us with any questions, or concerns, or show topic recommendations at info@pauseforthetruth.com. I would also like to give thanks to our behind-the-scenes technology engineer, Tyrone Jackson, owner and operator of Call Tyrone. Go to www.calltyrone.net for a complete list of services. Thank you for being a part of Pause for the Truth.